So I really have the honor today to introduce Dave Underriner. He is the 2015 recipient of OSU Alumni Fellow Award. So he is recommended by our faculty, nominated by our college leadership team. So even he is not our own graduate, and I'm going to tell you a little more about him. Dave is the CEO of Oregon Providence Health and Services, but his relationship with Providence actually started when he was born. He was born in a Providence hospital. I think it's in Spokane, Washington. That was Providence Sacred Heart. Yes, where his dad actually works there, and later on became the lay leaders of St. Vincent Medical Center. Of course, like many of teenagers, your dad is healthcare administration. Guess what? I'm going to go somewhere else. So he did. We're glad that he did, because he came to OSU and actually went to forestry, major in forestry management, and minor in business, and graduated at, I think it was 1981, if I remember right. So later on, after, of course, OSU is a great place, like many of the faculty here and students here. You know, we mentor, we always give you the right recipe for success. And that's how we did it, and how he received it, the helping hands, the mentoring, as well as give him the confidence that he needed and find his passion. Of course, that's when he went back to healthcare administration in 1984, received a master's degree. Unfortunately, this time we're not here yet then, so he received from University of Washington. So ever since he graduated, he works for Providence. So it's been more than 30 years. So now he's a CEO, working for Providence for more than 30 years. He oversees more than 17,000 employees and leads an integrated network that includes 8 hospitals, a health plan. As a matter of fact, I think my health plan says the last time I checked, see, it was Providence. So anyway, and also a long-term care facility. I have a feeling, I may have opportunities. Not quite yet, but I may. And the medical clinics and many, many more. He received, like many leaders, he received many awards and also sat on many boards. But I just want to mention a couple of them, why that we are interested in him, why his value really aligned with us well. For example, he really received the award as a Providence Health System Oregon Region Diversity Leadership Award. We talk about diversity. He also received, for example, Ethics in Business Award. We talk about ethics. So when he sit on the board, guess what board he sit on? The Janus Youth, I think I better say Youth Program, and also the Trillium Family Services. So no wonder our faculty would nominate and want me to nominate him, because his value, even his forestry, but we claim him anyway, because current leadership, what he's doing really reflect who he is and his value, and so much aligned with ours. But Dave and I sit on many panels, and we talk about healthcare reform. Even I don't know a thing, but I sit on a panel with him. But I always amazed how great his forward-thinking knowledge and very innovative solution for health system, and not worry about making mistake, take a test. And I said, you and I can learn a lot from you. But most things I care most about him, I want to say, is that I really value him as a leader. He's humble, approachable, and very human. So with that, I just want you to help me to welcome him to be here as our Alumni Fellow Award recipient.
Thank you, Tammy. That's very kind. That was very nice. You did your homework. All the way back to where I was born. That's Tammy.
The hospital wasn't easy.
No, that's. But thank you very much. It's a real honor to be recognized, and any recognition is really a reflection of the great people you work with and the teams that we have and the opportunities that I've had. So thank you. And even though I was in the School of Public Health, she said in the School of Forestry, which was a great program, continues to be a great one. Healthcare is very special. And when confronted with where to go and what to do, having grown up around healthcare, it was a decision that we certainly don't look back on, but certainly love being at Oregon State. The education here was tremendous, continues to be that way and growing, which is great. Just really, really value the time spent here, but what I learned here as a student and as, you know what it's like when you're moving from high school to college and learning to be more independent. Oregon State's a great place to do that. And it's great to see Oregon State growing. Wow, we were just walking around, holy cow. It's unbelievable. And that's building on the success of what the university's been able to do. So there's a lot of ways to go with this. Anytime along the way, if you have a question, want to challenge something, go for it. I have no problems with that at all. Actually, it's probably good to disagree because we're at a time where there's a lot of change going on and a lot of moving parts to healthcare. And we're learning. We're trying new things. A lot of things don't work. A lot of things do work. And it's actually a very exciting time. And depending on what perspective you all are participating in, wherever you're learning, you're probably hopefully finding that, not just the sort of the baseline of education, but really the understanding of how we're translating that into the world and the effect that we have on people. So I'm going to start with one of the biggest problems that we have is that we tend to judge in healthcare in general. And you're a sick patient, you have this or that. So I'm going to throw something out to you and see how you react. 3 years ago, I was diagnosed with prostate cancer. I went through treatment. It was very successful, and today I'm cancer-free. I had great treatment, great service, compassionate service, great support in the community. Pretty good, right? You hear that story a lot. Thank goodness. Now let me give you another perspective. 3 years ago, I was diagnosed as a schizophrenic. I'm on medication management. I'm able to work and do my job. I didn't have quite the support network. Frankly, people got worried about me. Weren't sure how to interact with me. Wasn't sure what that meant, that I had schizophrenia. Both are diseases. Both can be treated. And yet, look at our systems of care around each one. What do you see? Okay, I'm sorry. Yeah, go. Speak up. No.
Mental health isn't quite supported the way that other programs are.
Prisons.
And by the way, that's what happens. If I don't take my drugs or something happens, maybe I'm whatever reason, and I have an episode, I may end up in jail. Not in the hospital, or not in the provided, being provided by, having care provided by somebody who can treat me. It's very interesting, isn't it? And it's almost even how we fund and support what we do in healthcare. Not that any of it's easy, but look at the funding and support we have around traditional medical care. And then look at the systems that we have around behavioral health and addictions. And we put people in prison who shouldn't be in prison. We have people in our ERs. Any one day, if you want to come by Portland, come by one of our emergency departments, not just in Providence, you will find anywhere from 6 to 15 people waiting for mental health services in the emergency department. And we even try to put systems of care in the emergency department, which is a terrible place to provide behavioral health care, by the way. Doesn't work. And so, and yet we debate and debate and debate what to do around behavioral health. Really? What's the debate? We're a community. We all participate in the community. We're part of a community. We care about the people in our community, and yet we judge people who are mentally ill or addicted. By the way, we also judge people in poverty. I don't know, a lot of you in the studies that you do, and I'm very actively involved in work around poverty reduction. And we spend a lot of time destigmatizing and really understanding what it means to be in poverty. People don't, wake up today and say, I'm going to be in poverty and live in poverty, and I want a handout. Really? The circumstances that go on around how people end up in poverty and why it may be interim poverty or generational poverty are pervasive. They're really significant issues and community issues. And we it's sort of like behavioral health. We band-aid solutions in siloed buckets. Not the best way to do it. So we have opportunity to create different ways to do things. Politically challenging, it's hard to do, may cost money, may require investment. But if we don't, we're not going to deal with what we think we're talking about when we talk about population health and transformation. Right? So I just give you that framework. It drives me crazy, by the way. And we're having discussions in our organization around behavioral health. And we're a big provider, by the way. You probably don't know this, but we have 90 inpatient beds, both acute adult children. We have intensive outpatient services. We employ 20 psychiatrists. We have embedded behaviorists in primary care clinics. By the way, that's destigmatizing behavioral health care, because now in the interaction of primary care behaviorists in the office, the physician can assess and say, I'd like you to meet, go down and meet this person, who can then right there, same time, assess and begin to help deal with the underlying mental issues that may be going along with the physical issues. That's a great breakthrough. I think you're going to see that model grow and grow and grow. Destigmatizes better care and actually better health care, because now we deal with the full person, not just one. So we'll talk more about that. So just a little bit of a background about healthcare in Providence. So this is a typical day headlines. I probably like, you all read a lot, obviously, in school. So I get a lot of things every day. Some I read more quickly than others, but just to keep up with the trends. So here's a typical day. Headlines. Are Medicare ACOs working? Experts disagree. You guys may be debating that, right? It's a great debate. Experts disagree. Crunch time at small businesses as healthcare demands loom, right? Got to provide insurance. We got Cadillac taxes. We have all sorts of effects of the ACA. Do I provide insurance? Do I let my folks go in the individual exchange? What am I going to do? It's costing more money. Many low-income workers say no to health insurance. By the way, it's expensive. Even in subsidized healthcare, still has a cost. The CEO of Mayo, why Mayo Clinic doesn't want to acquire hospitals. You hear about mergers and acquisitions and consolidations, and that's why? Do we need more hospitals? Well, I'll make a pitch for that along the way of what's happening with the demographics. How an underfunded congressional program took down fast-rising Health Republic. You may have just heard the co-op, which is part of the health exchange in the small business, just announced that they're going out of business in Oregon. We work very closely with them. They rented our network, and we provided their ASO, or back office services. And they couldn't make it. It's 17,000 members. Higher healthcare costs, not a guarantee of quality. Boy, we know that one. And I think we're going to see a lot more challenge to how are we providing, what you're doing creating value. And I'll like to share some data. Okay, so Providence, some of you may have heard of Providence Health and Services, may have had interaction. It kind of depends on where you're from. So let me just give you a quick overview of Providence. We're in 5 states, so Alaska, Washington, Oregon, California. In California, mainly Southern California, the LA area. We have our system offices out of Renton, in the Seattle area. We have 77,000 employees across the 5 states. We employ almost 3,500 physicians, about 1,000 physicians here in Oregon. We have 25,000 registered nurses. We have 34 acute care hospitals, about 9,300 beds. Our health plan is about 500,000 members. That's a good sized health plan. We have 19 hospice and healthcare programs. 22 assisted living facilities. We serve 3.2 million people uniquely, so we don't count you every time as one. So if you have one encounter or 10, you're counted as one. So we serve 3.2 million people. Our total assets are about 15 billion, so a fairly large organization. And I'll talk a little bit about scale. We do almost $900 million of community benefit. In Oregon alone, we do $378 million of community benefit. So there's a lot of interplay and interaction that we have as an organization serving the community, not only through direct health care, but through many, many partnerships. So that's a little bit about us. We do about, it's interesting, on the charity care side, with the ACA, the Affordable Care Act, and expansion of Medicaid in Oregon, we've seen the amount of charity care drop significantly. That's a good thing. It means people have access to insurance. Access is a just thing. It's important. But the question is, as we've seen a reduction in charity, what are we doing to take those dollars that were typically charity care and turn that into supporting the community? And through partnerships, through programs and services that we do, but that many others do along the full continuum and along the notion of health. How do we impact the health of our communities? So I'm going to just sort of make a pitch for why we're not spending money the right way. So I'm going to start with a video. And some of you may have seen this or something like it, but it's just a couple minutes, but take a listen. Oops. What am I doing? Oh, here we go. Gotta do this. There we go. Now I got it. Okay.
It should come as no surprise that the U.S. spends a lot on healthcare. In 2013, we spent nearly $3 trillion, which is equivalent to 18% of our GDP. In fact, we spend more on healthcare per person than any other country in the world. Despite these costs, the U.S. is actually falling behind many other countries on a number of important health indicators, including the most important health indicator of all, life expectancy. 30 years ago, our average life expectancy ranked 15th in the world. Today, it ranks 43rd. So what's the problem? As it turns out, only a fraction of what affects our life expectancy is actually related to healthcare. Studies have shown that your zip code is more important than your genetic code when it comes to determining your health. To truly improve outcomes, we need to look beyond healthcare and a variety of factors that impact health. Things like access to housing, schools, jobs, the ability to exercise. Now, traditionally, the health and community development sectors have worked independently, but they don't have to. In fact, they really shouldn't. Let's take a look at this. Here's a map of Los Angeles County that highlights economic hardship. Here's a map that highlights childhood obesity. As you can see, basically the same map. Oftentimes, the health and community development sectors are working in the same areas. You don't even know about it. The good news is we're getting better at collaborating. More and more, we're starting to realize that the most impactful projects draw upon the expertise in many different fields. One example is the recent construction of Breathe homes by the Seattle Housing Authority, designed to reduce the effects of asthma. Now, asthma impacts millions of people in the U.S. each year. It costs the U.S. healthcare system billions of dollars. Recognizing the link between housing, environment, and health, the Seattle Housing Authority partnered with local government and academic professionals to raise funds for the construction of special affordable housing units designed to improve the internal air quality for residents. The slight improvements made to the design, materials, and construction of these homes led to residents having 63% more symptom-free days, fewer visits to the doctor's office, and less healthcare costs. Health-related investments are also becoming an attractive prospect for banks. Recently, Morgan Stanley, the Kresge Foundation, and LISC launched a $100 million investment fund designed to improve access to healthcare, housing, and provide services that connect the two in low-income communities. The fund will build 500 housing units with health services, construct 8 federally qualified health centers that are estimated to service 75,000 people, and create 1,400 jobs in struggling communities. These examples are representative of a larger exciting trend. As we establish new partnerships, we'll create new opportunities. We need more people to join the conversation. We need to leverage the expertise of leaders in finance, health systems, community development, and policy to create a marketplace that truly values health. And in this marketplace, everyone wins. To learn more about this initiative and how you can get involved, check out the resource section below.
Speak our language.
When I saw that, I thought, wow, that's what we're talking about. And look at the partnerships. It's business, it's healthcare, it's community, it's academic, it's policy, it's government. It's how do we look at it differently? How do we invest in it, but how do we develop program and service to make it happen? That's going to be how we change healthcare. So you may have seen this. It sort of reiterates his point. I won't spend too much time, but the average spending, the black line on the left side, we spend more money than any developed country in the world. And when you look at the GDP, 18% of GDP, and it's growing. We bent the curve a little bit. It's starting to move its way back up. And then on life expectancy. So now on the curve, I'm looking at how much we invest. So when you look at the health spending per capita against the life expectancy, we're not very good. Wow. That shouldn't be. We should be much, much better at this, but we don't connect all the dots, just like the previous presentation did. So we have an imperative. The last thing is so now you say, where are we spending money? If you look at the U.S. bar kind of in the middle, it's the black one that's part of the stuff, that's the percent spending on health services against social services. So we don't, in both, we don't spend as much as many countries, but a disproportionate amount spent on health services versus social services. That's got to change if we're going to really impact health in our communities. By the way, we're part of the problem. Providence, we're a very successful organization. We know how to deliver health care. We've got to figure out how to transform the organization to be a partner in doing these kind of things. By the way, we will always provide great acute care. People will have a need for acute care, ambulatory care, and so on. But what we hope is, through lots of work and through focus on how we look at serving populations, and I'll share some information on the difference, we won't need as many people in the hospital. People won't need to go to the hospital, which will be good. And when you do need to go there, it will truly be for the needs of the high-level expertise that is provided there. So new imperatives, form ACOs to capture lives. So we talked about ACOs, ACOs, accountable care organizations. You've seen one, you've seen one. They are very interesting organizational designs to serve a population. We have an ACO that serves Intel, about 12,000 lives. Intel said, we're spending too much money on healthcare. We want to work directly with you. They work with us and Kaiser, kind of two different plans, so they can compare and see how we do. Different constructs of health and health organizations. And we want a 15% reduction in our healthcare spend for our population. Well, how do you do that? So that's focusing on understanding now the 12,000 people that we serve. How do we keep them healthy? How do we make sure their access is correct, is easy access? If I have something going on, I have direct access to whatever level of provider I need. I'm in prevention services. I'm engaged in wellness activities. It's tracked, it's monitored. It's part of, probably incentivized in my health plan. If I do these things, I actually pay less out of pocket. All those things. And that 15% cost reduction helps Intel to be more competitive and helps their workforce to actually be working and not sick or not home or not dealing with illness. So far, we've been at it for a year. We're holding our own. But it's a very different way of thinking about how we do things. So you hear a lot about ACOs. A lot of the Medicare ACOs aren't working. I just saw that Dartmouth-Hitchcock was backing out of, they were one of the early pioneer ACOs with Medicare. They're backing out. I know the folks at Dartmouth-Hitchcock. Boy, are they data-driven? Do they understand, determinants of healthcare? And they couldn't make it work. And we're putting a lot into ACOs. And I think the construct is correct, but you have to think different as an organization. And the payer has to pay you different. I think that's the problem with Medicare. Medicare, if you ever want to do a case study on Medicare, look at Oregon. No good deed goes unpunished with Medicare, as an example. In other words, if you're lower cost, better utilization, you get paid less. If you're higher cost, more utilization, you get paid more. And if you do that over time, pretty soon you find yourself with getting paid a lot less for providing a very high level of quality with no margin in there at all. I mean, as a matter of fact, most organizations in Medicare, traditional Medicare, lose money through the current reimbursement system. And it's going to get way worse in terms of how we get paid. So a lot of us in Oregon, over 50% of Oregonians are in Medicare Advantage programs. And Medicare Advantage programs have flourished because they actually give you a chance to manage a premium and not having your good deed go unpunished, where you actually get some recognition and reward. It's a triple win. The enrollee wins, the member, the providers win, and the insurance factor wins because they're able to manage it. And it's a good program. So that's why you see a lot of MA, my speculation, in Oregon. And frankly, if you ask any provider, they'd say, I don't want to see traditional Medicare. Because we're doing a lot of services and the ways that we look at how we provide care for an MA population, and we're going to do that for traditional Medicare, for which we will not get paid for. So it's interesting. But ACOs are going to be important. We're going to need to continue to figure out how to do them and make them work. Measure lives, not admissions. You've heard this phrase, but understanding that we can work together with our members or wherever we're at risk or sharing in the insurance side, actually to understand how to best support the full continuum: wellness, prevention, illness intervention, chronic disease, wherever you are in that spectrum. I'll give you a great example. A program that we have, some of you may have heard of Elder Place. There's Elder Place programs throughout the country. We're the 5th largest Elder Place in Oregon, Providence. We have 1,100 enrollees, fully at risk for, it's dual eligible, Medicare, Medicaid, fully at risk, including housing. And when you look at, and to qualify, you have to be frail, elderly. So this is a pretty tough population. This is the typical population that you will see in and out of hospitals, really unmanaged for the most part. So they're very managed. And if you look at the satisfaction of the members that are part of Elder Place, very high. When you look at their healthcare spend, 50% less utilization of inpatient care, a better end-of-life care, more coordinated and structured, and it really works. And you ask yourself, why isn't that replicated? Good question. Well, it's hard to do. You got to take risk. I mean, there's some years that the utilization goes up because of the kind of person you're serving. And I think Medicare's not certain that they want to expand that kind of a program and fund it the way it needs to be funded, my speculation. But it works. Commit to total cost of care over time. You all know the cost equations, right? Unit of cost versus utilization equals total cost. It's about total cost. And a unit cost, yeah, I get, and that's where it gets a lot of press on the unit cost. But it's really about the total cost of care. When you look at serving, whether it's for an episode or whether it's for its population, how are you managing the total cost of care? And are you moving that dial? And when you get to a place where you really understand total cost and are recognized for that, whether it's through contracts or different things, it's actually very powerful. This is patient-centered medical homes on steroids. Y'all, y'all know patient-centered medical homes? Is that maybe a quick primer on it? So in primary care development, traditional primary care is an office. I think federally qualified health centers have been a little different. Actually, they've been more like what patient-centered medical homes have moved to now. But it's primary care. But it's primary care organized in a different way, where you've got your MAs and APPs, so nurse practitioners, PAs, physician, in your team, and they work in a team-based model of care, and they look at how they serve a population of folks. And there's certain criteria developed in terms of how you manage quality, how you manage outcomes, and how you manage that patient panel that you have. And the patient-centered medical home has evolved. There's criteria for qualifying to be patient-centered medical home. I'd say that's baseline table stakes. You got to ratchet it up from there in terms of really using your electronic medical record and information to understand who you're serving, to make sure that I'm managing my diabetes if I'm a diabetic. How do I know that? I know when I'm getting information back on your testing, or did you come in for your foot exams? You know, the kind of things that we know can help people manage diabetes and keep them from ending up in the emergency department of the hospital. So that patient-centered medical home is really designed to manage that care in a different way. And it works, actually. It works very well. It is really hard to change, though. And we've been at it for, 5 or 6 years, brutally painful change for our providers. But once they get through it and understand it and how it works, if you were to now ask, if I had brought one of our long-term primary care physicians up here, they'd say they love the model. It lets me practice where at my level of license, you know, that you hear that practice top of your license. And it really engages the nurse practitioners, the PAs, the MAs in providing care to a lot of folks. And from a patient perspective, you get the care you need right away. I mean, you get it where you need it and at the level you need it. All right. So the steroids is ramp it up, keep it going, and keep evolving it. Oops. Find and train population health leaders. Different way of thinking. Kind of what you're doing. I think as you look into the future, what's the kind of expertise we're going to need to have? It's around how we manage a population, how we think about the kind of services construct, how we engage with partnerships with federal and state organizations and community partnerships and bring those things together and demonstrate outcomes and understand the data and analytics and all those kind of things. Continuously improve cost structure goes without saying. By the way, at Providence, we went through a $250 million cost reduction in the last 3 years. Sounds like a lot. It was a lot. The problem with that is that's on a unit cost basis. It gets you to a foundation. There's not much more to do there. Where the real cost comes is in the kind of things we're talking about around inappropriate utilization. Why did you have 2 MRIs when you only needed 1? And by the way, did you even need 1? You should have been asking that question. And 2, and you all know Don Berwick, IHI, Institute of Healthcare Improvement, and the different IOM studies. There are things that we continue to do that are harmful to the people we serve, and there's a cost to that. And if we can reduce the cost of harm, better patient care, better experience, and it lowers the cost of care, I think that's where we're going to see the real, at least in the health care equation side, where you're going to see the costs coming out, and that will have direct benefit to me as a patient. How often do you hear, well, you guys are, some students in fact, if somebody goes into the hospital and they're pretty sick, do you worry about that? Not just about their health care, but is everybody talking to each other? Is everybody washing their hands every time they come in? And I read about, hospital-acquired infections. Is everybody paying attention to that every time they interact? Do people know what that last lab test was, the result? And is somebody acting on it? I'm telling you, and our people, I know on our teams, they work very hard. They're committed. It's an intense environment, and we don't have it nailed yet. So what happens? A lot of us spend time there. You become what's the right word? You're managing the care of your whoever's there, your loved one, your family, your friend. And it happens a lot. You hear that a lot. We can be way better than that. So that's what our teams are working on. Reserve capital for future losses. This is around this whole notion of risk, ACOs. You're managing a population. You gotta, it goes up and down. And when it goes down, you gotta have capital to make that happen. And AAA, you all know AAA? It's just like, it's table stakes in healthcare. You know, affordability, experience, really that best experience, and then demonstrated outcome. Whether that's the individual outcome or the community outcome, we actually made a difference. By the way, they added a fourth. Joy of the caregiver. You know, and the reason is, how do you get all that done if you don't have people that are passionate around the work they do and believe that they can make a difference? That was smart. I get that. So we have to work with our team. Okay. You've also seen this moving from visits, episodic care to populations and how we manage populations, and then really investing in that and what it looks like. Technology is fascinating in healthcare. If 10 years ago, if you'd asked me, I'd have thought we'd have seen a lot more technology actually than we're seeing today. It just takes a long time for healthcare to adopt new technology and to truly adopt it. I mean, there's a lot of things out there, but what's going to actually stick in terms of what's going to work? And by the way, that would have meant a lot more people not in hospitals because you can be treated at homes. Well, now, today, I think you're seeing it's moving fast now. We're starting to see technology being developed that can serve people in homes. I can do stuff on, I can pull out my app. I can pull out my phone now while we're here and call up a nurse practitioner and say, I got a runny nose and a headache. And she'll go, let me take a look, this, and that. And pretty soon I'll have a way to do my heartbeat and temperature. And she'll go, I think you just got the flu, go home. And I want to go to a doctor, I want to have to go in, and it'll cost me $39 to do that. Technology is fascinating, and it's across the whole spectrum, from the high-end research stuff around prevention, not prevention, but curing disease, to the prevention work and the interaction, the information. Okay. So I wanted to share this with you. We have this great debate of what's population health. Do you guys have that debate? Whenever I ask people what's population health, if we went around the room, you'd get some interesting impressions. Not always the same. And it depends on your frame. And my cynical framework is that healthcare uses population health to talk about managed care. But we don't like to say managed care because if you were around in the 90s, that wasn't a good thing. So we say population health. But when we say that to the School of Public Health, you go, well, wait a minute, whoa, that's not healthcare. I mean, that's part of it, but it's all this other stuff. So we had this, so our folks put this together, and I won't go through it in great detail, but comparing population health and community health in the parlance of how people use population health today. So you can see target population, group of patients identified based primarily on their insurance or payer, for which a network of providers assume risk. That's how population health is being used. But really, so if that's how we're using it, what we're really talking about in the broader context is community health. So groups of individuals identified by their place of residence. Back to your health may be more determined by your zip code, right? That's population health and a shared need. Funding mechanisms. So you've got risk arrangements and so on. This is our lens. Okay, this isn't full, but this is our community benefit dollars. How are we using community benefit in support of serving populations? Should we be looking at affordable housing? How are we looking at hunger, childhood obesity, different social determinants? That's where that comes from. Implementation, this talks about different ways, partnerships versus sort of a delivery system model, information decision making. How do we look at information? So in the population health, evidence-based, clinical best practices, those types of things, medical economics, population risk. In community, it's assessment and looking at improvement plans, engaging with advisory councils, listening to the community, understanding needs, and then developing services, and then actually measuring that you're having an effect on that part of the community that you're working with. The role of our health plan, emphasis on triple aim, so in the population health, it's reducing unnecessary costs and so on. But here, it's about improving quality of engagement through meeting core and basic needs, including healthcare, by the way, but many other things. Does that make sense?
Yes.
I don't know. You have to. The rhetoric can get really going here, and you can get sort of wound up around, where are we going to really have an impact? We've got to do both these things well. This is the game changer. We'll figure this part out, how to manage it, but if we don't do this really well, we're not going to do it. Okay. So I played baseball. So this is a little bit of a baseball analogy, and I won't dwell on it too much, but if you think about back to that construct of population health, community health, and what role that we're playing from a health system perspective, so from Providence, when we look at how we serve in the communities and what we do, this model gives you a framework so that, we can have some fun with a mitt and, catching the ball and, teams, because it's really all about teams. But what it highlights is that medical home we talked about becomes a critical place and a driver for how we serve populations. And it's a broad continuum. It's not just seeing a doctor. It's a retail visit. It's a management, all the way up to chronic disease management to its fullest. In the medical neighborhood, you may have heard of this, but this is engagement with specialists, so cardiologists and pulmonologists and GI docs working with the medical neighborhood of how to manage populations. By the way, one of our biggest spends is congestive heart failure. I don't know if that's a surprise, but what happens with congestive heart failure is it is a significant chronic disease. If not managed really well for the patient, they're in and out of the hospital, acute episodes, lots of things happening. But we know if we can connect through home services and having a way to track and monitor your weight every day, and things like that, and then having a connection with the cardiologist and the primary care physician and the patient and their team, that we can actually keep people out of the hospital, their disease better managed, they're functioning better, and so on. But you got to have a way to do that and coordinate it. It's got to be coordinated. Care management, huge area. The whole notion around, and this goes lots of directions in care management. From direct, acute care management, which is very limiting, to really population care management. And this is where you'll hear about resilience workers, community health workers. They're really care managers. They help people navigate across the spectrum. And including things like stable housing, including things like financial management, including things like family dynamic that's impacting their ability to take their meds every day. Whatever it is, that's got to be really tight. Retail access, the whole notion. What do you think? Do you think we had this great debate around healthcare? It's very personal, right? But don't you like convenience too? And what do you think about sort of this notion of I can get a lot of my healthcare done through electronic means or other means rather than direct personal contact? Do you think that's makes sense? Think so? Because this is a very interesting question, because you can debate, you look at industries, right, that have gone away because they didn't pay attention to what the consumer, in this case, and I'll use consumer because patients are consumers, they're making decisions. Are the disruptive technologies and changes really changing the whole landscape? Or am I being sort of old school thinking, well, there's still a direct relationship that people want to have around their health?
Probably varies by generation.
It varies by generation. Yeah, that's true.
A blend, having access to blend that.
It's a complex dynamic too, because it depends on what kind of situation you're in and what kind of access you're thinking about. I mean, in an emergency episode or a major event, obviously you want to go and get physical retail access. But if it's like, like you said, I have a runny nose. I don't need to drive all the way to my PCP and be like, yeah, I got a runny nose, and pay a copay and then charge my insurance company another $100, and then you can save that cost, and that's where this does come in handy.
I think you're right. I think it's a blend, and I think we have to pay very careful attention to what that experience can be like, and how do we connect that experience for folks. So anyway, behavioral health we talked about, and then social determinants. So really, that whole connection. If we don't do this, we've got a real problem. So that's the framework. All right, I know we're. And I put this up just as we think about populations and folks we're serving, the geriatric population, or the folks who are 65 and older, or however you want to define it. Although as I get closer to 65, I'm like, really? That's not the right thing. It's an older adult. Or the more experienced population, right?
Amazing one.
The amazing, as Ken would say, the amazing population. I think we're way underestimating the impact. The baby boomer generation, and as they're aging, is growing so fast. It's almost unmanageable right now, and we're seeing it. We actually see it in we're sort of say early on in the aging of the population. We're seeing a lot more people using healthcare services, and they're living longer. And I believe that we've got to figure out how to better manage and understand serving an older adult population. It's going to be different. It's going to be a lot of people. And if we don't do it well, it's going to cost way, way, way too much money. And it will be untenable. We won't, and therefore will create problems around access, around really providing the kind of care that's needed. This is a big deal. And there's tremendous opportunity to rethink how we serve older adults and how we create systems of care, how we look at home-based services, how we use technology, how we prevent falls, all the kind of stuff that happens. And then how we look at the disease process, and then how we look at end of life. Palliative care when I have life-threatening illness and diagnosed. End of life, what are my desires? How can I best be managed? How can I be pain-free? How can I, make the decisions that need to be made around that? I know you all work a lot on this. This is a huge area. And I think probably one of the most significant growth areas relative to really full continuums of service and care that we can develop. And any of you are interested in it and you're going that direction, good for you, because you will have lifelong work to do. Diverse populations, really understanding diversity and serving diverse populations. As a country, we're very much changing and becoming much more culturally diverse, and we need to understand that. One size does not fit all. How we provide services, how we connect and interact, whether that's through how we employ people in our organization and how we deliver care and what systems of care we have and how we connect. If we don't understand the cultural components of that, we miss the mark. And we're okay, but we have a lot to learn to do this much better. And that's across the whole continuum, back to the community health and community engagement. On the lower left is behavioral health. We talked about behavioral health. My guess, I think people have had it. I think it's kind of gotten to the point where people are now going to start to say we got to do something different with mental health and behavioral health. I know in our organization we had a very interesting discussion around what if we made a large investment in behavioral health across our service areas, and actually in partnership with the cities and the counties and the states and the community-based organizations, and said, enough's enough. The effects of what's going on are just untenable. We're actually going to invest a lot of money. Because part of it is what gets us from going there is the investment. People know. Tammy, probably someone here, I participated in studies on what we needed to do in Oregon to put into place a rational, well-organized mental health system. beautiful layout. Here's the services, and access, and all the way from residential to, that's going to cost $300 million over 2-3 years to invest in. Deal, done, discussion ends. No, you got to operate in the same budget. And so you go back to your corners and you do the best you can. Somewhere, somebody's going to say, no, we're going to make that investment. Because in 5 years, we'll have a lot less prisons. And by the way, that will more than have paid for it if you're looking for an economic return.
Yeah.
Direct. But frankly, what it'll do is for our population, for our people, we will actually have provided better care. And that's the true ROI. So I think this whole area, huge, big, and then kids. Right? I mean, kids just, so in the poverty work that we're doing, and I had a chance to participate in a poverty summit in Mexico, actually, of all places. This group came together from U.S. and Mexico and said, let's look at poverty. We don't have, our poverty levels here in the United States, it depends, but what are we at? 15, 20% poverty, which is a lot. And it depends on where you're at. It could be a lot more. In Mexico, 42% is in poverty. And so we came together, and these experts from all around the country, both countries, and they came to sort of present innovative ways to think about it. They've been working on all these things, studying it, but what would you do different to actually impact poverty? And then I was there. I'm like, why am I here? But because they were all these scholars and PhDs and all these people studying it, and then I'm like, healthcare provider. But in Oregon, the business community has said poverty is important. And there's a thing called the Oregon Business Plan. Every year it's revised to say, how do we grow Oregon? How do we invest in Oregon? I said, we have a disconnect in a couple of places. One is we need a workforce, and we don't have the right workforce. We don't have enough people trained. So there's a disconnect. And then we have people who are unemployed. And then we have poverty. And so we said, well, can we figure this one out? I mean, now, understanding very complex problem, but one. Two, as business, we should care a lot about poverty. We're in this community, we're in these communities. Poverty is a significant issue we should care about. So in the Oregon Business Plan, we have a focus on poverty and poverty reduction, working with community partners, state, and others. And it's very interesting. And what we've spent a lot of time is learning what does it mean to be in poverty. And there's a lot of reasons why people are in poverty, and there's a lot of programs and services that kind of help, but really don't. But at the end of the day, so of all this, so back to this forum, there were two things that came out. Jobs create dignity, actually having work, and meaningful work. And two, create a good childhood for every kid. A good childhood, not a great one. And one of the scholars had done a study of how much we spend on the high end for kids and the low end for kids. And it was like, if you just think of the costs, all the things, it was a threefold difference from the low end to the high end. And if you just go to the middle and create a good childhood and define what good means. But frankly, so much of what happens is, you see this, I mean, if kids, the ACEs, the different things, if not having a good childhood just sets you back. I mean, you're just, all the way from, by the way, where you're a normal birth weight baby. We know that just from there, the data shows that if not, I mean, you got a path. I mean, you got a lot of work to do. Early childhood development, 3rd and 4th graders, and reading by 3rd grade, 9th grade count. You go through all this continuum of things. What if we committed to creating a good childhood for every kid, every child? We've got a lot of work to do there, and it cuts into all sorts of policy issues and funding issues and societal issues. But you're back to the social determinants, aren't you? And if we don't create jobs, we're going to continue to have a problem because people don't get work. If I don't get work, then and so a lot of emphasis on CTE training, on going on to undergraduate, graduate school, getting the both training, but it's all the above. It doesn't have to be getting a higher education degree. It's developing a skill. And then it's creating the jobs to make that happen. And by the way, at that summit, people were like, where are the jobs going to come from in 20 years? Everything's automated and mechanized, and what jobs are there going to be? Well, I don't know. We have lots of data to analyze. We've got lots of services to still provide. I mean, you sort of, but we've got to be training the workforce to make that. All right. So, just a couple of things. We must be willing to let go of the life we planned so as to have the life that is waiting for us. Challenge ourselves, right? Put your interest in the future because you're going to spend the rest of your life there. That's right. I mean, what we're doing today, we're creating for, that should be a pretty good motivation. And then lastly, the difficulty of life, not so much in developing new ideas as escaping the old ones. By the way, probably if you talk to folks, the biggest fear that you have is the phrase, well, this is the way we do it. Really? I mean, that reference should only be good as experiential knowledge to ask a question, not for how we should keep doing it. And it is amazing how we get stuck on the way that we've done things and can rationalize it. Am I telling the truth here? Because I find that myself doing this. And so, as students and others, you get to keep pushing, and that's what I love about in our organization. It's a very transparent, very open, questioning, asking the question, why do we do it this way? Because if you don't, we're not gonna get to all this stuff. And boy, there's so many ideas and just things waiting to happen if we unleash it and unlock it and are open to it. So I don't know if there's any questions you have, or does that gives you a framework of some things?
Now you can see why we claim him one right? And also, we very, very proudly saying that we're the future of public health is here. And many of you probably heard of the college. Many of the things you're talking about, that's really the composite as well as the framework for our college. And also that's part of the reason last couple of years I'm trying to, and with many others, to really reach out to the healthcare system, is because we need to learn from each other. So with that, I thank you, but I want to open up for question and comment. Any question, comment? Yes, please.
So you'd mentioned the cost of technology being about $39 for that scenario that you mentioned.
Well,
right?
That was our charge. I mean, that's what you would pay.
Okay, so that's a charge. Okay, so I was wondering, from an implementation standpoint, have you done something like that yet? Is there a test model that you've worked on? Is there an implementation on a smaller population? Where are you at from a technology standpoint?
Yeah, so we put it in place. It's interesting. The first one we did, and it was a visit actually through a computer screen. So that was the first, and we did it with PEB, Portland Public Employee Benefit Board in Salem. So the folks working, state workers could actually go use it. We started with that, and we still use that opportunity to go to a place and interact electronically. But what we've done now is we've expanded to using the apps on the smartphones, and it's up and running. So, but we do it. We have a continuum. So we have the computer base you can go to. You can go via the app, and you can actually do e-visits too. You can text and get a response back. So you can even do that. So the technology exists, and it actually works pretty well.
Just one follow-up question. What were the legislative challenges that you faced with that? Because I don't know if legislation is as clear on the use of technology, and that's my area of interest, and it's what I've been trying to figure out.
Yeah. So the last legislative session did pass the telehealth bill, so there's an opportunity now to be paid for providing telehealth visits within a framework, and that's good, because along this whole continuum, even the whole telemedicine opportunity is huge. I mean, this is how we're going to provide care in many areas. Take Oregon. We're not going to be able to have providers across all the communities that need to have providers, but if we can link up through telemedicine, we can leverage and use the expertise through that mechanism. So you have one specialist serving 15 communities, which is probably good. And so we're going to see the expansion because now the mechanisms exist to pay for it. Now we have a health plan, so a lot of what we did, like with this Health Express, is our health plan pays for it.
Right.
So for the populations we're serving, we provide it to you, and the health plan's agreed to pay for it. Now the interesting other part is if you're a physician and you have a panel, and I go through there, and I'm paid on production, I didn't see you, therefore it may affect my income. So now we're having to look at how we compensate physicians, because you want to incent, seeing people, but you want to incent seeing them differently. So now we have practices. So we're moving a little bit more to salaried models. So I'll give you a good example in infectious disease. They set up an afternoon a day, and there's 4 of them, they rotate, and they do electronic consults. So a primary care physician sees you, sends the chart, and it's all, by the way, we didn't talk much about the electronic medical record or health record, but we're all in Epic, so says, I'd like you to take a look at Mrs. Smith, here's what I saw, and that ID doc, instead of waiting for 2 weeks to get in and so on, actually pulls up the chart, reviews the chart, reviews the notes, does a consult on the chart, sends a note back and says, no, I need to see her, or no, this is based on what you've identified, no, you've diagnosed it correctly. And they've built in a model to do it so that you don't have to have a face-to-face visit. I think this is going to be where a lot of this.
Still get paid though for that consult?
Still gets paid. Yep. Different way.
Right. Right.
I was wondering more about the community benefit dollars. Sounds like that's kind of the major way that these hospital systems are going to be working on social determinants of health. So I think a lot of that was affected by the Affordable Care Act. So I just wondering more about like where it comes from and also how you quantify something like that.
Community benefit?
Yeah.
So community benefit, there's actually formal designations of community benefit. The state of Oregon defines what's included in a community benefit. Otherwise, we'd all be throwing stuff in there, right? Just make it sound good. Can't do that. We all have to follow a common formula and it includes a category of things. One is charity care. So those who are uninsured, where you provide service and they don't pay for it, that's community benefit. What's not paid from Medicaid. So Medicaid pays below cost. It's about 68 cents on the dollar. So that difference you can count as community benefit. In Oregon, they let you count what Medicare doesn't pay below your total cost. Our measure, I told you the 378 million, that's the Oregon measure. Our measure using the Catholic Hospital Association measure, which doesn't allow you to use Medicare, that's a little bit you could argue that one a little bit. It's about 240 million, so you can see the difference. But you can include the unpaid cost of Medicare and Medicaid, and then in-kind services that you provide. So where we might have a partnership where we support affordable housing, and we work with the food bank, or we do things, or I spend time doing this, or our employees are volunteering out in the community, and we track those, and it's very tightly defined and very specific to actual work being done that's in service to the community. And you add all those things up, and that gives you the community benefit. So what's happened in the hydraulic of that is that charity care, 8% of our gross charges were charity care. It went to 2%. That's a pretty significant reduction in charity care. That means our community benefit went down. Now, some would argue, well, hospitals are just making a bunch more money, and we should tax them. This is my day. We should tax you, or we should force you to do more charity care. There's a lot of pressures. And what we've said is, no, what we ought to do, what we're committed to do is, if we're doing less charity care, how are we translating that back up into serving the community. And frankly, to be honest, I mean, charity care is a failure of our healthcare system. Really? I mean, to be without insurance and with limited resources, and you know, we're an open door. And we studied this, by the way. We did, through our Centers of Outcome Research and Education with MIT and Harvard and others, studied the effect of being uninsured, not having insurance versus being insured. By the way, you can never do a blinded study like that, right? You have insurance, you don't have insurance. What? Whoa, whoa, whoa. Who said I don't get insurance in that thing? You know? But in Oregon, we had this thing called the lottery before we did the expansion of Medicaid. So, because we only funded it so much, so you went in the lottery, yes, I got insurance, or no, you didn't get insurance. So, but for a researcher, this was your double blind, you know, and they jumped all over it and said, what does it mean to be uninsured? And we have myths about this, don't we? I mean, we have all these